Here we go. So we have two speakers today, and I'm going to introduce them both now, and then we'll do one after the other. So we have Dr. DSouza, who is an ICU fellow on rotation with us here at VGH. And he is presenting to transfuse or not to transfuse, prediction of massive transfusion with the revised assessment of bleeding and transfusion score at Canadian Level 1 trauma centers. And that will be followed by Dr. Hutspardol, who is our transfusion medicine lead here at Vancouver General Hospital. And she will be talking about ROTEM uses in trauma MHP at Vancouver General Hospital's experience. So I will stop my share and let Karen take it away. There we go. Yep, we can see your slides.
Perfect. Thank you so much. So good morning, everybody. And I really want to thank my transfusion medicine colleagues for organizing these rounds. And I'm excited to share this project, which is actually a few years old now, but still important work to share on behalf of my team, as well as my principal investigator, Dr. Phil Daw, as well as some of my transfusion medicine colleagues, Dr. Shi, Dr. Wong, and Dr. Yan. We have no conflicts of interest to share with you today, but if anybody has any suggestions, just let me know. So trauma is an often overlooked contributor to morbidity and mortality in Canada. And this is despite it being the leading cause of mortality in people that are younger than the age of 35. Approximately 30 to 40% of trauma deaths are due to exsanguination and hemorrhagic shock. And between 20 to 36% of these deaths are potentially preventable with advanced resuscitation techniques. Stabilization through rapid delivery of massive transfusion protocols remains a foundational life-saving intervention in addition to control of hemorrhage. Any temporal delays in the time between activation of a massive transfusion and the actual administration of blood products decrease its efficacy and lead to a 5% increase in the odds of mortality with every minute that is delayed. So to address this, the need for early identification of patients needing massive transfusions, there have been sort of many different kind of scoring systems that have been created over a long period of time. And so we decided to study a couple of them that have been either the most popular or ones that are of interest. So we studied the well-studied ABC score, which is the assessment of blood consumption score. And the pros of this is that it really uses quickly available data points, vital sign parameters, fast exam results, and mechanism of injury to predict the need for massive transfusion. And it's been widely used, and these metrics are point of care, unlike previously when we used to use maybe a CBC or an INR or PTT that would take a bit more time. And as I mentioned, delays are detrimental to our patients' care. What we were really interested in was the the RABBIT score. So it's a newly developed score, and it stands for the Revised Assessment of Bleeding and Transfusion Score. And the differences here is that it uses shock index instead of heart rate and systolic blood pressure independently. And this has a better predictive power than the individual metric alone. And the RABBIT also adds the presence of pelvic fractures as a high-risk mechanism, because when they had reviewed the ABC score, they found that people that were falsely negative were suffering from pelvic traumas that were often missed. And this is especially important in Canada, where the proportion of blunt trauma is far exceeds our proportion of penetrating trauma. In a recent, not so recent, but a multi-center US-based validation study, the RABBIT score actually outperformed the ABC score in terms of sensitivity and specificity in predicting the need for massive transfusion. But I would say that when we're considering both of these scoring systems, the one thing that we should take into account is that they're both disadvantaged by the same thing, which is the use of the FAST. The FAST is an ultrasound-based study that is done at the bedside to predict these MTPs, but ultrasound, as you know, is operator dependent and adds a great deal of subjectivity to the score, whether it's an R1 doing the exam or if it's a staff. and but on the other hand, the FAST is fairly positive in the right upper quadrant, which is the easiest to attain. So perhaps it's still a valid metric to add to these scores. So therefore, the aim of our study was to test the feasibility and the validity of using the rabbit score in comparison to the ABC score. And we also decided to study the shock index just by a standalone metric by itself to assess the need for massive transfusion protocol in severely injured trauma patients at two major Canadian level 1 trauma centers in BC, which was Royal Columbian Hospital and VGH. So we undertook a multi-center retrospective cohort-based study that used two different databases, the Trauma Services BC Registry Comprehensive Database and the Transfusion Medicine Services Database, in order to identify over a 5-year period between 2015 and 2020, any adult trauma patient age greater than 18 suffering from a major trauma mechanism, meeting the regional criteria for a trauma team activation, and receiving at least 1 unit of packed red blood cells within the first 24 hours of their admission. These are the people that were included, and the people that were included were people who were dead on arrival to the emergency department, or those who had no FAST exam results, as that was a key component of both scoring tools. So in total, we reviewed 1,725 patients, and in the end, we had sorry, I'm going to stay on this screen here. We had 514 that met inclusion criteria and were included in our analysis. The majority of the patients were young males, which is unsurprising, and they all actually suffered fairly severe injuries, as demonstrated by their median injury severity score of 29, which is out of 75. Unsurprisingly, the mechanism of injury was mostly blunt in nature. Although I think it's important to note here, the pelvic fracture rate in our study was 28.6% who had suspected or radiologically proven pelvic fractures. And this was nearly double the percent amount that was seen in the US-based study. In our study, we also decided to use two different definitions for massive transfusion. Massive transfusions have commonly been defined in the research domain and in the literature as the administration of greater than or equal to 10 units of packed red blood cells in 24 hours. But given that this definition is fairly lengthy and retrospective in nature, we felt a more clinically relevant definition was needed. And in the literature, one that was commonly being used was 3 units of packed red blood cells in the first 3 hours. And that was the one that we also studied. Our overall rate of massive transfusion using the research definition was 15%, and using the clinical definition was 40.3%. So here we see that the overall sensitivity and specificity of the ABC and rabbit score were a little bit lower than previously reported in the US-based study. But given that this was the first study to be completed and validate the score outside of the US population and trauma demographic, this is not entirely unexpected. However, in comparing our diagnostic accuracy values to other international validation studies of the better known ABC score, our results were congruent. So these, I think, are valid results. And through looking at this database, data set that you can see here, there was no statistically significant difference that was found, and the rabbit score was modestly improved, provided a modestly improved sensitivity and specificity. And given that we don't want to miss any patients that may need a massive transfusion, a slightly higher sensitivity is preferred. Here we look at the receiver operating characteristic curves, which were fairly similar for all the scores. When you look at I think the most interesting thing here was actually the shock index. Sorry, I don't know why it's advancing by itself here. The shock index. So shock index actually emerged as a very reliable and accurate way of correlating decreased tissue perfusion and a better indicator of occult or compensated states of hemodynamic instability rather than the individual vital sign parameters alone. Hence, its similar performance to the other scores is actually, and its considerably simpler calculation, suggests that it may be of great interest to Canadian centers, especially our rural locations that are in access and weather challenged geographic locations, and where these patients are major trauma patients are often being cared for by physicians rather who are not necessarily traumatologists. As predicted, our study did have a higher prevalence of pelvic trauma. And one of the questions that was often asked within the literature is, does it matter what type of pelvic fracture? Is it unstable pelvic fractures that would garner more of would be more important to identify rather than just any pelvic fracture itself? So here we see that we actually took all of our pelvic fractures and did a sub-analysis. We used the Young-Burgess classification scale to identify unstable versus stable fractures. And we just wanted to see the sensitivity and specificity of the Rabbit score based on if we included all pelvic fractures or just the unstable ones. And as you can see here, there was no significant difference. So all pelvic fractures should be included in these scores. So our study was certainly not without its limitations. It's retrospective in nature. It uses a database that can have incorrect entries. We also had a smaller patient cohort than the initial validation studies. The FAST exam, as I mentioned previously, is operator dependent. And also one thing to note is we often had to not include certain patients who didn't have FAST exam results. And it depends on the center that you're working at. So at VGH, our CT scanner is immediately next to the emergency or the trauma bay. And so at times, our rapid access to CT imaging and well-developed protocols results in us taking patients straight to the scanner rather than doing a FAST. And so that may underestimate the diagnostic value of these scores. However, oh gosh, okay. However, this is to our knowledge the first validation study of the Rabbit score outside of the United States. I did look up last night any new studies that have come out. There is one South American study that did look at the Rabbit ABC score and shock index, and they had very similar results to us. And so this is important work, and I think the most important one is that both scores, I think, are equally valid and can be used. I wondered if the Rabbit score would be better for the Canadian population, given that we have far more blunt trauma patients, and certainly might be better utilized in the community. But I think shock index really came through as an important standalone metric, and it's easily calculated by physicians. It has the potential to be a dynamic score because you can recalculate it fairly easily by just putting the heart rate over the systolic blood pressure, and it can help you sort of see how you're going during the trauma resuscitation and should be sort of investigated in greater detail. And then further national studies where we're including other trauma centers outside of British Columbia to better understand the discriminatory power of these tools is going to be important so that we can see how it is replicable in a variety of regional settings. So with that, thank you so much for your attention and happy to answer any questions now or later.
Thank you so much. I think we have time for questions now. Sakura, do you have a question? You came on, or is that just coming on for your talk? Does anybody have any questions for now, or we can wait till Sakura's done? Looks like nothing burning. Okay, I will let you get started with yours, Sakura.
Okay, that's great, Karen. I actually have a question for you, but I'll leave it to the end. And I'll make sure that everyone had rooms and times for Q&A at the end. So thanks again for opportunity to speak here today at the transfusion round, and thanks for introduction. So we're keeping on with the same theme of trauma and bleeding management, massive hemorrhage protocol, and happy to share you the experience of the test that we use here is we can talk about the role of it in terms of, how it works and, being used as a point of care based or lab-based testing to guide the massive hemorrhage protocol, particularly for the trauma-based that how we did it at Vancouver General Hospital. Apparently on the right-hand side here is not me, but is one of the main player that, delivering ROTEM test results for you day to day. Jeffrey Chang is our Heme TC. So I have no relevant disclosure to this talk today. So first, we have to start off with when we implement ROTEM at Vancouver General Hospital, cannot be done without Dr. Jackie Trudeau, our anesthesiologist, who also had, expertise in transfusion. So as you can see from the algorithm here, we have 3-4 different ROTEM-based algorithm, depends on patient's population and the location. Very similar in terms of the algorithm, when to parameter and what to, transfuse in terms of blood product. But as you can see here, that it started off with patients that had clinically significant bleeding. And, when the resuscitation happened at a trauma bay, so when patients first arrive, the massive hemorrhage protocol activation for trauma specific will be activated, and the blood that will be delivered to the trauma bay will be based on the protocol that we design for trauma, MHP specific. So look at the 4 columns here. So first one is using the XTEM-A10 with the FibTEM-A10 altogether. If they both low, then that's indicate to get 4 grams of fibrinogen. If XTEM-A10 is low, but FibTEM-A10 is rock solid, then give 1 adult dose of platelets. And then clot time by XTEM as well. If it's over 100, then you have to optimize the clotting factor. In this case, we recommend weight-based frozen plasma. You can use SDP as well, so 15 mils per kilogram. And it's up to provider who resuscitate the patient that they wanted to go directed therapy, but at the same time making sure that note and recorded that how many red cells been given, or maybe trying to using balanced resuscitation technique or whatsoever. So that will be left up to the provider. And the last column is the maximum lysis time at 30 minutes. If it's over 10, then that's indicate hyperfibrinolysis, and the tranexamic acid of 2 grams should be given. So for the trauma exsanguinous, or so-called massive hemorrhage protocol for trauma at VGH, first pot will be 4 red cells, and 4 plasma, could be emergency supply, could be group specific. So when the first pot went out, you set the timer. So at the same time, right, think about you have pretal plasma, you give it like 4 units given, and you start throwing more plasma. So it could take 15, 20 minutes or whatsoever, but we set a timer at around 10 minutes. So what do? We call down to offer fibrinogen, and at the same time, the reconstitution process of fibrinogen will be happening in the lab. And then we prepare, and then we call down and check. Most of the time, because of how chaotic it is, whoever answers the phone will always, yes, never heard any no from the trauma bay. And then we don't, as you can imagine, technologists don't get involved in terms of the ROTEM interpretation, but around 10 to 15 minutes is the time that ROTEM results should be available, and the provider who resuscitate the patient, practically based on the protocol, they should look into the value and decide, going back to the previous slide, that what components they will be given or not given, and up to them. And then after that, if it continues, so the second part will be delivered for trauma bay, we use the pneumatic tube. All the product can go in within like seconds. So it's the same, 4 red cell, 4 plasma, and then we give platelets at the end. And we also issue the calcium flasher to remind that, after 4 units of this product, which has had citrate, a lot of citrate, then you should give calcium to the patient. So the implementation for ROTEM happened in 2016, and the trauma group who very interested and they follow the protocol according to the agreement. The team led by Mina, she's a former research fellow for trauma. So she looked into comparing the usage of blood between before and after ROTEM was implemented at VGH. And she wanted to see that how ROTEM impact the blood product treatment decision. So this is the findings. As you can see, pre and post ROTEM, no major change, not significant in terms of the difference of how much red cell has been given, plasma and platelets. I think it's by the time people use more fibrinogen as well, but you can see that the use of fibrinogen is actually jumped after ROTEM has been implemented. I just want to emphasize that these 2 periods for the patient's population, they were matched in terms of age, sex, the mechanisms of trauma, injury severity score, mortality, and they have coagulopathy, but as you can see, very soft core, right? 1.2, that's considered a match for both groups. And also this group received more than 10 units of red cell, which is based on the definition of massive hemorrhage protocol. So looking into frequency of the blood components has been given. So you can see the fibrinogen usage is jumped after ROTEM has been implemented. On the right-hand side, you look at the components ratio comparing to the red cell. So ideally, if you follow goal-directed treatment, then you should maybe use less plasma. Never know, maybe use less platelets. But from our observation, Mina's observation, the ratio of FP versus red cell, platelets versus red cell, is unchanged, only fibrinogen usage that went up significantly. And when I joined VGH, I realized that when I look at the massive hemorrhage protocol for trauma in terms of blood work, what are the initial blood works that include in the auto set? Of course, paperwork. And I asked a question to my colleague, Tyler Smith and Andrew. Oh, we actually offer both. We offer both ROTEM and we offer both CCT, conventional coagulation tests, PT, INR, PTT, and CLAUS all at once. So my question is, which one that the trauma surgeon follow? Did they actually follow it? Did they adhere to the protocol? What are the impacts? When you have ROTEM, is that any improvement of the survival as well? And then impact to the transition medicine in terms of utilization, workload. And same questions apply to our hematology lab in both workload and utilization. So I asked our trauma surgeon, who's part of this study, Dr. Howie Hawes, do you follow it? Do you look at it? I guess you're busy, you're resuscitating the patient, you're probably doing some maneuver like thoracotomy or whatsoever, trying to control the bleeding. Do you actually have time to look into it and follow the protocol? The luxury of Vancouver General Hospital is we have a group of anesthesiologists who specialize in trauma, and there are 6 of them that had the rotation that, they're on call for 1 day a week or whatsoever. And once, there's a major trauma happen, and there's a potential that this patient is so sick and it's going to be transferred to the OR for the damage control surgery, anesthesiologists will go down to the trauma bay and start, getting involved in the resuscitation and also aids trauma surgeon. And after that, by talking to anesthesiologists, I understand that they quite religiously follow ROTEM. And this is one of my buddy, Hutspardol, trauma anesthesiologist. So we look into it. We look into, okay, if I wanted to compare the outcome and the blood use, comparing between conventional coagulation test and ROTEM, and how is it define, identify traumas-induced coagulopathy, and what are the impacts? I was able to do that because, we have both tests as part of the EXP blood work, initial blood work. And, with involvement with amazing trainees, Jenna Croker, she practices in the US right now, Jenny Wang, our HIMPAD resident, and Tyrone, the research student. So they help with the research as well to make it happen. So look at the trauma MHP activation. I just want to highlight that this is the initial assessment. This does not capture the resuscitation or all the follow through in terms of blood components, product that were given down the road, because MHP can last hours, right? And then 55% of our patients went to the operating room and had the damage control surgery. So those cases had way more variability in terms of the severity and everything that happened in the OR. So this is an initial blood work comparing between ROTEM and CCT. And the parameters that I use for the CCT based algorithm is based on the regional VCH and provincial trauma algorithm that we recommend that, okay, if the INR is over 1.8, then you should get frozen plasma or SDP. If PTT is over 1.5 times of upper normal limit, then you give FP, or fibrinogen less than 1.5, then you give fibrinogen. It's just because the rural side, the regional side, they don't have ROTEM. And I heard so many times, when I gave a talk or presentation, people ask, unfortunately, we don't have ROTEM. And I was like, really? Is that really unfortunately that not to have ROTEM? So you'll see. My question is about, I wanted to know the performance. I don't compare the speed. And I was able to do that. It's just because of the super efficient workflow in my hematology lab. And these are people who make it happen. Tyler Smith and Jim, our lead, right? Anytime people heard that VGH analytical turnaround time of CCT, including Klaus fibrinogen, is 10 to 15 minutes. Everyone jaw drop, was like, how is it possible? But again, it's not only that, right? Analytical time, 10 to 15 minutes. You have to think about pre-analytical time. Who take the blood, who run the blood, who take the blood to Heme lab, and the readiness of our technologists to make this happen and get the result out as soon as possible. It's all, all the credits go to them, right? One thing that, I have to kind of explain to you that there might be a concern if you want to compare the turnaround time is if the fibrinogen is lower than 1.1, we prompt our machine to reanalyze, to repeat the testing. So you had additional 5 to 6 minutes to repeat the test. So in that case, if you deal with lower Klaus fibrinogen lower than 1.11, then it takes additional time. So the turnaround time would change to be around 20 to 21 minutes. And again, another thing that that hyperfibrinolysis can only be assessed by ROTEM, but not by conventional coagulation tests. But again, our BCHS, whenever they pick up trauma cases and the bleeding is evident, they always give 2 grams of tranexamic acid stat. So how often do we still see hyperfibrinolysis on arrival? And that's another argument that people said, I don't know about hyperfibrinolysis if I don't have ROTEM. So that's another question, research question I want to look at too. So, and this is the finding, the result. So over 2 years, we were able to capture 68 patients that had both CCT and ROTEM done all together at once on arrival. So 49% had normal CCT and ROTEM at presentation, 32 only had abnormal ROTEM but normal CCT according to parameter I described, and 19% they both abnormal. For the 32% or 22 patients, the abnormalities by ROTEMs are isolated 15, 18, less than 10. And then there's some, small number of patients that had everything all abnormal. And by the time that, sometime with the initial blood work, you have insufficient blood volume in the tube, you have to call out, you have to get a repeat. All of these cases, luckily, they had ROTEM completed, like enough blood to run ROTEM. Fibrinogen is actually considered add-on that if you want more blood, you call down, and then you ask to take more blood for fibrinogen testing. With that, with the whole process, we had additional 7 cases that had hypofibrinogenemia based on Klaus fibrinogen. No surprise, patients that had abnormal initial ROTEM received more blood at both first 4 hours and 24 hours. Look at the sensitivity again. 49% had abnormal A10 less than 10, and then 29% that had Klaus less than 1.5. Both groups justify that they fit with the definition of massive hemorrhage protocol. And then if you want to correlate the abnormalities to the mortality to see that does it make any difference, the red boxes represent the one that had statistically significant in terms of the mortality outcome at 24 and 28 days for the all-cause mortality. If patients presented with abnormal initial CCT, had low Klaus fibrinogen, and had low Glasgow Coma Scale equal less than 3, then higher likelihood that they will pass. And then you don't see the same, difference in terms of outcome if patient presented with abnormal initial ROTEM of 15A10. So the conclusion is ROTEM is very sensitive in identifying trauma-induced coagulopathy, particularly the 15 value. Both patients that had abnormal initial ROTEM and CCT, ROTEM didn't change, didn't reduce plasma requirement, platelet requirement. They both require a lot of everything all across. Abnormal ROTEM, abnormal CCT led to increased death rate, higher death rate, but you didn't see the same, increased death rate or all-cause mortality in patients that presented with initial abnormal initial ROTEM, sorry. That leads to the question of if you deal with a test that is so sensitive, right? It leads to higher use of fibrinogen. It might be a good thing. So first, I think, okay, if it's so sensitive that detect abnormalities early, maybe you can control bleeding early. Maybe you can use less plasma red cell platelets down the road if you're able to stop bleeding earlier. Maybe there's a survival impact that we didn't see here in our observation. What else? Increased sensitivity can lead to more fibrinogen use, and that is also money and workload. And not only TM lab, this is a workload that we capture by both methods. And thanks to Jeff and Kevin again for the contribution of the cost calculation. As you can see, right, right column, cost of ROTEM as per 2025 compared to dirt cheap CCT, very, very cheap, as you can see. And it comes down to the technologist time. Analytical time is the same, 10 to 15 minutes, but technologist time is you spend approximately 6 minutes for ROTEM. We always keep the reagent outside, it's good for 8 hours, and we use it all the time. And then you require technologists to keep pipetting because we use Delta. We didn't have money to buy Sigma, and we're not sure that we're going to buy it. And then 1 minute to clean. If you deal with CCT, you use 5 minutes to centrifuge, the blood sample, and then tech can do something else and come back and spend another 20 to 30 seconds just to load and transfer. So approximately the same time in terms of the technology's time. Looking to the evidence out there in terms of, resuscitation based on two different methods, which one is better? So the yellow highlight studies are the one that show some benefit of using VEA, viscoelastic assay, to assist trauma resuscitation, and the rest are the one that didn't show any survival benefit. For the one that positive, and it's probably the one that we refer to, despite we using the different parameter for resuscitation. So for the tech one, as you can see that they use the lysis percent of 5, not 10. And then for ACT by tech, they use 128. But they also give a lot of blood. If you look at the CCT parameter, if INR is more than 1.5, then you give plasma, but like half the volume that we give here at VGH. And the platelets threshold is actually 100, not 50, and what we follow. So it's a lot of detail that you have to look when you really analyze the study, that what you want to follow, what parameter you want to follow, and the algorithm that if it's abnormal, how do you define abnormalities, and what are you going to give as a, to resuscitate the patient to correct the coagulopathy, right? This one, Gonzalez, is the same one that showed that using tech-based algorithm can improve 28 days survival. The conventional coagulation test group received more plasma and platelets. So the conclusion is tech-guided treatment leads to more judicious use of blood product. However, the group that used CCT received more cryoprecipitate, which is like, I'm not sure why it happened that way. This is the one, this is a major one that I think, the resident fellows should know about. ITACTIC study is the one that also RCT or randomized, VEA versus conventional coagulation test. They use a combination of ROTEM and TEC based on the study site. What they found is no difference in overall outcome between, VEA, VHA, and CCT. Going back to the same question, more sensitive, what does it lead to? So if you think that we can detect low fibrinogen much faster, what are you going to do with that information? Cryostat 2 had demonstrated that high dose, big dose of fibrinogen by cryoprecipitate empirically in the first 4 hours of trauma event did not improve clinical outcome. So the same group, Davenport, also look into, they did the systematic review and look at the values of giving fibrinogen earlier within 4 hours of the trauma event to see that it make any change, and the same, no. So that means like little hour study, right? It's sensitive, but so what? What are you going to do about that? Yeah, this is just to show you there's no difference in terms of survival between standard and giving the high dose fibrinogen. Maybe 4 hours is not the right question. Maybe you have to be more feisty. So feisty is another one that's still going on. So the feisty one had demonstrated is a time that when Australia and New Zealand want to change from cryoprecipitate to fibrinogen. So they look into how much time that you require to prep the product, and then what is the outcome in terms of what is a delta of the 15A10, 15A5 that you can achieve and fibrinogen level. Unfortunately, there's more death in the fibrinogen concentrate arm, and that leads to FISD2 that's still going on. Is a phase 3 randomized trial that trying to enroll 850 patients, and they want to give fibrinogen early, but the cutoff is not 4 hours like Davenport in Cryostat 2. They wanted to look into giving fibrinogen within first hour and see what happened. So their primary outcome is that survival at the 90 days of the injury. At the end, my message will be not sure that one test will make a big difference. As you all know, that trauma care is a coordinated care, right? Right from who activate BCHS, when BCHS get there, what kind of care they can deliver, transfer to the hospital, whatever going on at trauma bay, inpatient ICU, and anything that can help patient recovery. Going back to current presentation, you look at blunt trauma. These are all blunt trauma. Can you really standardize, your assessment and explain what impact the outcome the most? Again, cannot do this without my team, transfusion medicine here at VGH and VCH. They are the biggest part of the one of the biggest part of the trauma resuscitation. And yeah, thank you for your attention.
Thank you so much, Sakara. Apologies, I got a phone call halfway through, so I missed part of it. But I do have a question for you before waiting for questions from the audience. So particularly, you mentioned that the fibrinogen A10 or on the ROTEM was more sensitive than our traditional Klaus fibrinogen. I may have missed it, but is there a thought or a possibility that we're just using different, like wrong cutoffs, or one we should up the cutoff and one we should lower the cutoff?
That's a great question, Krista. Many of you know, same as Royal Columbian, they were part of the FARIS 2 study, not for trauma, but for cardiac cases. They used a different cutoff. They used the FIB-10 A10 of lower than 8, not 10. And that's kind of trying to balance out the fibrinogen concentrate amount that we use to resuscitate. So I asked Kevan Kakruti when I saw him 2 weeks ago that, yeah, you different. And most of the trial use 10, some trial even use 12, which is going to translate to a lot of fibrinogen, right? So I asked him like how, your team and SEOJ's team comfortable with this lower cutoff. And he actually said it's very experience-based. If you don't achieve bleeding control with using number of 8, then you move up to 10. But then that is not going to be captured by the study, right? We have to stick with the protocol when you do a study. But that is something that I'm seriously considering, that maybe our threshold is way too sensitive. Yeah. Okay, Tyler is the one who can answer that probably.
Oh, no, I can't answer it, but what I can add is when we first set up the ROTEM, we did do a validation of the cutoffs using like normal cohort. But again, I don't know, I've never looked side by side at what our normal cohort cutoffs for Klaus fibrinogen, for instance. Like we set the 10 based on both what was recommended and in a way what we had from our normal controls. But I've never actually gone back and looked at, like, if you look at normal controls on a Klaus fibrinogen, how it compares to the normal control set for the ROTEM. But certainly, like, that's, regardless of, what the rationale is, there's clearly a consistent pattern across everything using ROTEM and Klaus, where you do see this difference if you use the 10 cutoff. So, although, it's funny because when I was a resident, we used to use, even though the Klaus fibrinogen cutoff was 1.5, we used to not recommend transfusing cryo/fibrinogen until Klaus was below 1.0 grams per liter, even though the normal range was 1.5. And then eventually that shifted, the conventional approach shifted to 1.5. But so just because something's a normal limit, even on your validation, doesn't mean it has to be what you use as a treatment threshold.
Right, and then translate to cryostat, they use the cutoff of 2 of fibrinogen, and now we know that we don't need it.
Yeah.
Someone need to do a trial for 1.5 or maybe 1.8. I don't know what is going to come up next.
Yeah.
Yeah. Okay, we have a question in the chat and then Nick. So apologies if this is answered. I heard that in Canada we have more blunt force traumas in contrast to other countries. Why is this? Karan, that's for you.
Yeah. I would not necessarily say to a lot like the Europeans. I think they do have a fair bit of blunt trauma as well. I just think in proportionality, our friends south of the border tend to use their guns a lot more often than we do. And so their volume of penetrating trauma is significantly higher. Just to give you a sense, I was just talking to one of my colleagues who works in Texas, and I would say at VGH we maybe do like 15 to 20 thoracotomies a year. They do about 3 to 5 a day. That's their volume of penetrating trauma at their location.
Thanks so much. Nick.
Hi, thanks. So that's a great presentation, both of you. I had a question about your awesome turnaround times for your coagulation-based testing. Is that from receipt to report or just purely on instrument time? And second question is, I mean, those times are very similar to ROTEM. Like, do the clinicians still use the ROTEM only then, or do they look at both? Like, how do they actually use the different information nowadays?
Tyler, thanks for the question, Nick. Tyler can add at the end, but the way we capture is the time that it got to the lab. So ROTEM time will be all the ROTEM specimen will have the orange tape, like, that's to code that do not centrifuge the sample. So someone will run the sample to the hematology lab. And the time that capture 10 to 15 minutes is the time that when we receive the sample. So I think I mentioned, right, how important of the pre-analytical part that all code-related sample has to be delivered directly to the heme to the point that, hey, this is a sample for you, do it. And it cannot be sit and wait because this is hard to handle. 10 to 15 minutes is a time that our hematology technologists had a hands on the sample. So your next question about the adherence to the protocol for trauma surgeon, according to my survey, verbal survey, meet a few of them and ask them, they actually, because it's so chaotic, so they said, yeah, if we know about it, they will fix it. But because of the support that we have for the VGH trauma, that any serious case, there will be anesthesiologists that run down and help the case. So according to the anesthesiologists, they use ROTEM-based algorithm.
I think alongside that, Kate is asking a question. Did the PPA staff actually place this into the centrifuge and start for the heme techs? That would be for conventional coags. And the answer is yes. So they are accessioning and then putting it in directly to the centrifuge. So that is why the turnaround times are better for our conventional, like better than a lot of places for our conventional coag. Erica, you have a question?
Yeah, thanks. Hi, I'm Erica Lester. I'm one of the trauma surgeons from Edmonton. So thanks for letting me join you around. So that was great talks. I'm part of a QI project at the UAH was introducing ROTEM for trauma transfusion. So that's why I'm here and why I'm so interested. I just a quick question. My other hat is my background's in health economics. So I noticed your cost slide, and I was just wondering, are the costs that you've listed there, is that simply for reagents, or is that also including the time for the techs who are running those tests? So in essence, I guess my question is, how did you calculate those costs?
Great question, Erica, and thanks for joining. Those are reagent costs and consumable, any consumable, because you have to buy the cup as well, right? And all the pipette. The take time is calculated and is quite equivalent at 6 minutes of the take time. So I think I show 5 minutes for really prep the reagent and loading it because we use Delta. I think if you use Sigma, there's some automatic whatever process there, and then 1 minute to clean up to run the next case. For conventional coag, the take time is 5 minutes for they start the centrifugation, but 5 minutes can be used for something else. They can move around and then come back and grab the tube and then load the specimen for 30 seconds to the analyzer. So depends on how you calculate, right? If they don't have anything to do, maybe they might hang around with the centrifuge, but practically because we run ROTEM constantly throughout the day, those 5 minutes, if you calculate and say that they can leave the centrifuge and do something else, that is also should be calculated into the equation.
So your ROTEM is being run in the same lab?
Yep.
Oh,
Main hematology
okay.
lab. Yeah.
Cool.
Very
Yeah,
close, right next to each other.
That's great. Ours is right in the trauma down in the Hemorrhage, so I think it's just a different setup. And my last question pertaining to that is here in Edmonton, my understanding of the lab, and I've never been up there, is that when there's a massive hemorrhage protocol, it diverts one tech to only running the conventional labs for that. So it's obviously a major resource, especially at night when there's lots of other urgent blood work that needs to be done. Is that what happens in your lab as well?
Yeah, so trauma always happen at night,
Yeah.
right? Like after 7 p.m. to 4 a.m. in the morning is a peak trauma time.
Mm-hmm.
And yeah, sometimes when our tech run very at the schedule level, it's really major. And our tech, right? Because it's a main hematology lab, we not only serve trauma, we serve everyone. We serve
Yeah.
OR, we serve ICU as well, if
Mhm.
it's indicated. So it's quite serious when it's busy.
Yeah. And that's a big question for me in this QI process we're going through, is because I learned that through this process and getting the grants and everything, that we were having one tech who got dedicated to running labs when there was an MHP. And it's like, wow, that's a big human resource, especially at night, like you mentioned. So I was just curious to see if that was a problem, not a problem, but a feature of the system in other places. Thank you so much for letting me join the presentation. That was really
You're
great.
welcome.
Yeah, Sakara, was the $46 you quoted for the ROTEM, was that for one test or for the XTEM and FibTem together?
Together.
Yeah. Because Kate said they've been quoted closer to $100 for Sigma cartridges, but that's because with the Sigma cartridge you have to do 4 tests. So it makes sense that it would be kind of double the cost. So even though you save tech time with the Sigma because you're using a cartridge system, the downside is you're potentially having to spend more for analysis because you're basically doing 4 tests, whereas with the Delta, you can, in theory, do just the ones you want.
So I have a question, Sakura, because from what I understand, most of these patients are getting both ROTEM and conventional coag simultaneously, correct?
Correct.
What are your thoughts on the environmental impact of that? Because the ROTEM and conventional coags are similar tubes, but they have to have 2 separate tubes.
I mean, it's obviously more, so it's not ideal, especially if they're giving overlapping information. I think, I mean, I don't know how consistent, and I'd be curious about Erica's thoughts in Edmonton, but here in Vancouver, I've heard quite a range of opinions about ROTEM amongst trauma surgeons. I've heard some that think it's basically telling them nothing else that they don't already get from conventional tests, to others being like, ROTEM's better, we should drop conventional tests. So, you could argue, I guess, maybe dropping one or the other from an environmental impact standpoint. The thing you potentially lose is um, potentially the ability to do these kind of analyses that Sakara mentioned. And also, I'm reluctant to get people too dependent on ROTEM because, conventional tests obviously are a lot more economical. So if they can do just one or the other, I'd rather they do conventional tests. I mean, that's kind of the problem is that, so even though there's environmental impact and I guess a cost impact, I'd rather the approach be conventional test as the default and only ROTEM for situations where they need it.
Tyler, I might be a bit biased because I was one of the physicians who was a driving force behind the introduction of ROTEM. So I think that probably speaks to how I feel about it. I trained in the United States as well, so perhaps there's some, as they say, drinking of the Kool-Aid that occurred. But I would say personally that I find ROTEM incredibly helpful. I agree what was said before is that it's so hard to study this. You can't really have two identical trauma patients. So it's really hard to know the counterfactual, and it's really hard to run a really solid RCT. And I know they've been done, but I recognize how challenging they are in this area. So I think it's very reliable, and anecdotally feel as well that we see really good results. And I don't tend to look at conventional testing myself. But again, I recognize I speak with a lot of bias in that. Because I really felt strongly that it was something that would be helpful to introduce into our environment. But I know the evidence supports it to some degree, but it's not clinched or cinched for sure. So that would be, and Edmonton this is new for us. This is why we've approached it from a QI standpoint and sort of iterative reassessments, because it's we're trying to see if it works in our system. As opposed to just saying black or white, this, works in other centers, so obviously it'll work for us.
I tuned in a few minutes into the talk, so I didn't see if Sakara presented this, but at our center, it took us about a year of collaborative, multidisciplinary meetings to get ROTEM set up and funded here. So it's definitely a long process to go through. And I would encourage you to feel free to email me offline. Just if you want to discuss some of the practicalities of getting it up and running, I can share our experiences and what we found helpful and where we had snags.
And speaking from the VGH sort of standpoint, my background is in general surgery as well, and so we love it. And also in the ICU, we do use it quite a bit. I think especially in major trauma or specific ICU patients, I do find it particularly helpful. And also in those patients who are transitioning to the operating room, where I think our anesthesia colleagues are use ROTEM quite a bit in terms of their resuscitation, both using both ROTEM as well as TEE guided resuscitation. They kind of use that together. I think that's it allows for a continuity of care that I think makes sense for those specific types of patients. But as usual, how do you identify those patients from the outset is the kind of key question for us.
Yes, and you make a good point that in Edmonton, I'd see that anecdotally. We have a pretty big cardiac program. So one of those anesthesiologists happens to be around for these traumas. ROTEM is definitely looked at much more than conventional testing because they're so familiar with it and so confident with it. And they've had ROTEM going in the Mesenkowski or the cardiac center here for much longer than I've got ROTEM running the emergency department for trauma.
One last question I have from Nick out. Do you limit the time when ROTEM can be run, i.e. only during initial test results and then switch to conventional coags only later? I think our answer is no. It's a good thought though, Nick. And ours, I think it's different from what Erica's group is doing there in Edmonton. Ours is physically in the lab. So any group that wants ROTEM testing can theoretically order it with some limitations, I think, of wards. Like we're not as generous when it's coming from a ward that it has to go through a pathologist for the most part, unless they're sort of pre-liver transplant or something that would indicate that they would need a ROTEM.
And those orange labeled tubes, they're really only available in Emerge Trauma Bay, OR, and ICU. And those are the kind of pre-approved ordering locations.
But thank you, everybody, for the wonderful rounds. Thank you, Karan and Sakara, for your talks. And again, you'll get that little link. Please copy it and do the evaluations. And we'll love to see you back next time. Have a great day, everybody.
Great talk, Sakara.